and we are starting our instruction course number 241, Refractive Surgery Options and Decision Making. And it will have three talks. One is the refractive surgery spectrum that I will take, and then second talk will be corneal procedures, indications and considerations for 20 minutes. That is for Dr. Bhupesh Singh to take. And the third talk will be lens-based refractive surgery options, investigations and considerations. That will be Dr. Purendra Bhasin to talk about. So it will be a comprehensive course of refractive surgery options where we'll talk about basically all the kinds of surgeries which are available in our armamentarium as of now. And these are actually very interesting times for a refractive surgeon because we have a large area, large options, large plethora of options available for us to manage every kind of refractive error which is available, from a small power of -1, which is probably the minimum you want to correct, up to whatever you want to correct, like 30 or whatever, because then you have options of bioptics and trioptics also. And there are options for very severe kind of disorders where you can do multiple surgeries to manage like abnormal conditions also. So we'll be taking all the conditions one by one. And the overview of the refractive surgery is we have myopia, and to correct myopia we have corneal procedures like LASIK, epi-LASIK, PRK, LASIK, intracorneal rings and inlays, Scara rings which are no more used but definitely intact are still in vogue. Lens-based procedures like phakic IOLs and clear lens extraction with multifocal IOL implantation. For hypermetropia, we have corneal procedures like LASIK and surface ablation, and lens-based procedures like phakic IOLs. And I can tell you, with all these options, we are looking at an extreme level of accuracy of almost 90% people getting fantastic results and satisfactory results, and they are very happy to have. And for astigmatism, we have procedures LASIK, other all laser procedures, along with query arcuate keratotomy. Why query is very few people are probably now practicing keratotomies, though I did keratotomies earlier in my practice in 1985 to 95, and a lot of arcuate, radial and astigmatic keratotomies in my practice with fantastic results. I still see these patients after 30-35 years of their procedures, and they are pretty happy. They come back to me for whatever problems, if there are any, they have, and they still consult, and they've been happy for more than 20 years, so they have a lot of faith. And for astigmatism, we have toric ICLs, which are now becoming the in thing, because lot of these procedures like laser and other procedures are they involve a lot of cost, both for investigations and also for the performing the procedure. So ICL is an easy procedure for anyone who is practicing cataract surgeon, and do an ICL without much investment in the machinery, but and give excellent results. Presbyopia is another field which is coming up very, very nicely, and we have presbyopic LASIK, press beyond and other things. Conductive keratoplasty has been given up as of now because these procedures were more kind of used almost 20 years ago, but now this conductive keratoplasty is no more practiced, but lens-based procedure like pre-lax presbyopic lens exchange and multifocal IOL is very much existent in today's world. And also recently there are a lot of people who are doing multifocal or presbyopic ICL for correction of presbyopia in patients of age group of 45 to 60, and they're giving excellent results unless there is a cataract development. For them, we'll talk about, if the time permits, we'll talk about the procedures which are available for presbyopia, including the ICLs. This is a radial keratotomy. If you have not seen it, these are the marks, and the radial cuts were made at a depth of 90% of the cornea, making sure that there is no corneal perforation, because if the corneal perforation develops, uh, then there is a possibility of development of cataract or iris atrophy. But if there is a corneal perforation, very small micro perforation, which does not cause any flattening of the antechamber, then probably it's not a matter where one has to be very careful, because 90% depth is also very close to uh, nearly, and if you press harder at one point, sometimes there is a little bit of oozing of aqueous, like in this particular case, and then you have to irrigate these cuts very gently so that there is no debris remaining in these cuts, because this debris remaining in the cuts causes a lot of epithelial kind of nests, and can cause trouble in the later time. Uh, I started in 1992. I had a machine called ALK, which was making the flap, and the second pass, one pass will make a flap, and the second pass will cut the lenticule. This was the first procedure, lenticule-based procedure at that point in time, when there was no laser, femtosecond laser available, and you could regulate the size of the lenticule and the thickness of the lenticule and correct very high myopia, anything more than 6 or 8 diopters of myopia. In all these cases, I don't have a video, though I might have done few hundreds of these ALK procedures in my time. The only problem was that it was not possible to correct astigmatism in this lenticule procedure, which was after making the flap, which was possible by doing with the excimer laser, but it was very accurate procedure, or not so accurate, but reasonably accurate for people up to about more than 12 diopters also. Sometimes I did, I think 14 diopters also in these cases. Depending on the thickness of the cornea, you could go up to correction of 14 diopters in these cases. And this was a decent procedure. This ALK keratome, I got it in 1992, and then in 1995 I got the excimer laser. That was the first excimer laser for LASIK procedure in the city at that point in time. And initially I used this auto ALK keratome for making flaps of 120 to 160 microns for doing a LASIK in my own practice, and it was decent. I think I continued with this for more than about 3 or 4 years, after which I purchased a dedicated keratome for making flap only. ALK was not actually only for flap, it was for like correction of myopia by creating a lenticule, and also correction of hypermetropia by making a thicker flap, so that there is a weakness in the bed, and there was a little bit of protrusion of the cornea in the center, though it was not very accurate, but it was correcting a little bit of hypermetropia, like 4 diopters or so, very peacefully. And also it was also the ALK procedure was also good for making a very thick flap of 300 or 400 microns, or even that much, for a lamellar keratoplasty. So that you could take a thick flap, thick lenticule, flap, and then cut it according to your size, and then put it as a procedure for lamellar keratoplasty. Then in 1995, I had this LASIK, and this is a very old video, probably not recent, because at that point in time, this is the time when I started using that Moria keratome. So this is the time, and this is everybody is doing LASIK nowadays, but this is one of the few, since this course is not complete without showing these procedures. So this is a flap creation and then laser, and as you can see here, the astigmatic correction was also possible with excimer laser, and that is why this came into vogue, because the results were very accurate and were very stable for a very, very long time. There was probably regression 5 to 10 years down the line, but not much to the extent that majority of my patients who were done almost 20, 30 years back, they are still very happy and they are coming back for their cataract surgery. Now they are in the age group of 60 or so, 55, 60, 65. So these were the, and also in LASIK, the advantage was, like in this particular case, this was a small aberration correction with the segmental ablation by Nidec system, and this was correcting the aberrations also in the cornea. So the quality of vision was also superior to just correcting the aspheric or spherical ablations. So this was LASIK, and then you wanted to kind of wash the interface so that there was no debris and there was no epithelial ingrowth after this. So gently I needed to wash the underface and then interface wash and then put the flap back, so that there was a smooth, adhesion of the flap on this bed, and then you could see the majority of these patients were seeing as much as the best corrected visual acuity the next morning, and they were very good. The wow factor was there. The wow factor with the radial keratotomy was also very good, and wow factor was with LASIK was even superior to what we had with the radial cuts. So this was another procedure which was available, and then came the after LASIK, when the ectasia was recognized, then we realized that there's not a good idea to make a thick flap, because the flap thickness was not as accurate as today's with the femtosecond laser. So we made a small well, and with the alcohol, and then removed the flap of the epithelium and ablated on the surface itself. The idea was that if you did a PRK directly, then because of the epithelium not being there, there was a lot more haze as compared to with the LASIK. So this was something which I did, and with good. So in my practice initially, when I had the excimer laser, I never did PRK, but because I was not convinced with the kind of haze, because at that point in time mitomycin C was not available, and since mitomycin C was not available, we did not have any control. And here you can appreciate that all the alcohol was taken away from the top, and there was no alcohol spillage on the area which was not meant to be touched with alcohol. So but any case, PRK I did not do initially, because of the reason that I was not convinced, because of the brown irises and our tendency to develop more reticular haze. But with the LASIK, when you removed the epithelium with the alcohol or with the epilasic, the epithelium, when it was put back, it took care of the the reticular haze, and not much of reticular haze was seen, and also it was not having a lot of pain also, because the exposure of the nerves was not very much. So both ways, this epilasic and LASIK alcohol induced corneal flap of epithelial flap was very successful in taking care of the epithelial haze, corneal haze, reticular haze, and also the 20 minutes. कितना टाइम हो गया? 20 मिनट्स हो गए? नहीं, 20 मिनट्स पे तो so this epithelium was reflected back like a flap in the LASIK, and then laser was performed, and then I'll take it forward so that, and this way the laser was done, you know, having a Marusel sponge on the epithelial flap, which was otherwise also pretty kind of thin. And since these patients, this was done in all the patients which had higher power. So that is why you can appreciate that was much smaller ablation zone with much deeper ablation. And both astigmatism and spherical powers were were able to be corrected in all these cases. So then after that, a little bit of mitomycin C with the sponge. So this was very important because when mitomycin C came into picture, then only we were able to take care of the reticular haze, and then I started doing surface ablations. Before that I never did, because couple of cases at that point in time, initially I saw the other surgeons, they were having only -2 to -4 power, but had developed a reticular haze. Maybe because of the broad beam lasers which were available, maybe because of the fluence of the laser was not as good as otherwise, but reticular haze was seen in quite a number of patients, and in all those patients even a retreatment will not take care of the reticular haze. So that is why this was something which was there. And after that, remove the mitomycin C sponge and put the flap back very gently, and this will take care of the, and after this you put a contact lens. But the beauty of this thing was that the haze was not there and pain was not much as compared to what we see in trans PRK today. The pain was not the matter at that point in time with LASIK, or so then you put the contact lens over the, and that was it. And then came the femtosecond laser LASIK. Okay, I'll skip this. I'll continue with this procedure, this here. So this was the the femtosecond laser. In my case, it was a Z LASIK, only because the reason that Zimmer was the machine which I had by, and they called their procedure as Z LASIK, the Zimmer LASIK, the femtosecond laser. So there was this cone which was to be centered on the cornea, and then initially this Zimmer machine had a raster pattern of laser cutting the flap. So it was like laser going this and then this and then this, like this. Multiple time it will go across. Here you can appreciate that multiple time it will go across and make a linear cuts in the with the edge here. So these were the linear cuts you can appreciate, and then this was the edge which was created. This is very early in femtosecond laser LASIK. This was in 2007. This video belongs to that time. And now the laser which is available for making the flap and the lenticule, they go round and round and make the cut in a circular manner. But that time it was a raster pattern, and the adhesions were a matter of significance. So you could not lift the whole flap at one go. So gently you had to kind of separate and break the adhesions initially, and then one or two swipes it would take to lift the flap completely. And then after that, The same excimer laser will continue for this procedure, like here. After lifting the flap, you could do a excimer laser correction. At this point in time, around this point in time, there was a iris pattern capture, and also pupil center capture was also available. So after some time, there was not much of an issue of decentered ablation. Initially, the decentered ablation was a problem in LASIK, but later on, when the pupil capture and iris pattern capture, the correction of the astigmatism and also correction of the or centration of the ablation was not much of an issue, and it gradually became more and more accurate, more centered ablation, and then same thing which was kind of there before. So this was something which was, and the femtosecond laser flap, which was more or less absolutely planar flap, not like a meniscus with the keratome. So the thickness of the flap was perfectly same all around. So the chances of thinner flap in the center and flap stria was also taken care of. These flaps were much more accurate, much better. Size was much under control. Whether the corneal curvature was flatter or steeper, the size of flap was very accurate. And then this is a procedure I just wanted to show that this is a procedure where I had done a keratoplasty, and when I am doing this, flap is going beyond the keratoplasty scar. This was a young girl when I did the keratoplasty. In early cases, the girl was around 5 or 6 years of age. I did the keratoplasty, and then after that, this is the laser going on. As I explained, this is a raster pattern, and once we made the flap, the laser was very efficient even in the areas where corneal opacity was there, and flap was not torn because of the corneal opacity. So the accuracy of the femtosecond laser is very nice. Even in radial cuts and all, you can do the cataract also in all these cases. And now the most recent thing is the smile. So this is the smile which we got in 2018. This is another procedure which is available and very accurate, and I'm sure quite a number of you of people have seen smile and other procedures which are lenticule procedures. Now there are 3 procedures available: the smile, the elita or silk, and also the clear. The clear procedure is also available, and here we do a dissection of the lenticule, anterior plane and the posterior plane. Both are separated one by one, and then you pull the lenticule out. Like a little bit of adhesions if are there, then you can just pull them out by doing a rhexis kind of tearing, and that is done. So this is again a new procedure which I got recently about 5-6 years back, which is called clear. So clear is, here is the animation of the clear procedure. There is a vacuum you create, and then, sorry, what happened? Yeah. And the centration in clear is immediate. The axis of the clear procedure is, once you have marked 180 degree at 180 degree at the cornea, in the periphery, the machine captures the 180 degree axis perfectly, and then, why it is not running? Okay. And then it cuts the posterior and then the anterior plane. The beauty of this clear procedure is the distance, working distance is smaller, focus size is smaller, and also the separation of the pulse is not like other machines in Zimmer or Silk, in Zeiss or Silk. So here the separation is, they are overlapping spots, so there is hardly any tissue adhesions, and you can have two ports to dissect the lenticle, and one by one you can dissect the anterior and posterior, and then you can probably either pull it out, or you can just push some BSS, and the lenticle comes out. So this is, here it is. You have to prepare the laser before you can do this, so that you have to put the SIMK values, and also put the Q factor. So Q factor comes in the pentacam, it is minus 0.22, and then pachymetry you have to fill in the machine. Once you have put the pachymetry reading, then the power to be corrected, and I have personally corrected minus 4.5 astigmatism with this procedure. Here in the initial stages, this is the 2.5 with and there was hardly any target refraction. We always wanted to keep something like 0.25 on the positive side, so that there is, even if there is a regression, so there was no problem on that. And then you cut the anterior and posterior planes. It captures the pupil, captures the 180-degree axis, or if it is not capturing the center of the pupil, you can make it in the manually, you can center the machine laser ablation, and then you cut, whether you want to cut two ports or single port, depends. If you are comfortable, you can make two ports, or you want to make one port, that is fine. Or you can make two ports and use one. That is also possible. And then it cuts. And also the beauty of this system is that there are, if you see, there are two venting tunnels. So the earlier machines had a problem that these gas would vent into the antechamber or above and rupture the cornea. So in all these cases, the venting was something which was helping for the gas will not escape from other routes except for where you want it to go in the venting tunnels. And once it has done the cuts in the anterior and posterior, you can create the port, and after that you can go through this port to take the lenticule out. And I can tell you, this lenticule procedure is also very, very accurate. Majority of times you will find that all these patients are nearly 6 the next morning. So this is very, very accurate procedure. And there is initial few cases, 10 to 15 cases, where you need to kind of optimize the energy and optimize the laser and find out what kind of errors you are looking at. Once you have done those 10 to 15 cases, after that accuracy is very nice and you can be very confident. We are using it for now 5 years, and with utmost accuracy. I am doing SMILE for a longer period, of course. Clear came much later. So you can do the separation of the, and here I made two ports, but there is no need to use the second port. The lenticule is being separated, the posterior plane, and once you have separated the posterior plane also, you can pull the lenticule out. Initially, you need to pull the lenticule out, later on with the crocodile forceps, but later on you can just push it out with the flow of BSS. So suggested treatment algorithm, I have already talked about that, but patient with sufficient corneal tissue, all kind of LASIK or clear or lenticular is possible. Insufficient corneal tissue, epi-LASIK, PRK, submovement keratomelusis or femtosecond laser. As a law, you cannot do a normal LASIK for anything less than 490 micron corneal thickness, normal. So you cannot do a microkeratome LASIK even if the power is low. So mind it, you can only do a surface or other than the normal LASIK and especially femtosecond laser. And then in insufficient corneal thickness, the choice probably between phakic IOLs and clear lens extraction. Low myopia who require reversibility, you can do ICL, presbyopia, presbyopic lens exchange or presbyopic LASIK or presbyopic ICL which is now available. And then hyperopia, wave front guided or ICL and astigmatism. We all know excimer laser based or toric phakic IOL or intracorneal rings, especially in the cases of keratoconus. So conclusion, various treatment options are available. Customize the treatment to the patient needs, and also you can have a bioptics so that you can correct a larger correction. Current options, as I've already discussed, bioptics. Thank you very much. Now I will invite Dr. Bhupesh Singh. He will be talking on corneal procedures, indications and considerations.
इस पे नहीं चलेगा चलो वहीं जाते हैं फोन कर लो सीधा लगा दो
Okay, go ahead.
So, good afternoon, good morning everyone, and I'll be talking about corneal procedures, indication and consideration. I think we have seen all the surgeries in detail and we all know that how to perform these procedures. So we'll be talking about some of the pre-operative decision making, counseling of the patient, expectation, and when not to do procedures and how to choose these procedures. So straightforward, we are going to the selection criteria for laser procedures, because this is the most toughest job for the LASIK surgeon or refractive surgeon, how to decide whether we should go for surgery or not. So some of the basic criteria by which you can screen the patient in your optometry room only. For example, if the individual is less than 18 years, there is no point of getting the examination done also. Just straightforward, give glasses and send the patient off. So refraction has to be stable for at least 1 year. If some patient is of age of above 25, you can still consider lesser duration, maybe 6 months or 9 months, that is good enough. But younger the patient, you have to wait more to become stable. Again, corneal thickness, which is the cutoff of my practice, is 480 micron. I don't touch patients less than 480. If it is less than 480, it's better to go for ICL. Whether if the number is 3 or 4 diopter also, then also ICL is the preferred procedure in these cases. And absence of any significant ocular pathology. So all refractive patient has to be screened thoroughly for the entire segment examination, cornea, lens, iris, pupil size, and the most important is the retina examination. So retina Dilated retina examination is a must. In diaphthalmoscopy, look for the lattices and holes. And if it is there, just secure those things. Again, one more thing we have to look is amblyopia, because many of high myope patients are amblyopic. So you have to see what is the best corrected visual acuity after the refraction. You have to counsel the patient accordingly about the expectation, because if you don't tell them about the amblyopia, patient will demand 6/6 post-operatively. Then it's very difficult to defend yourself. And it's always better to note on the worksheet or in the patient's notes that he is having amblyopia and the vision will be suboptimal post-operatively. Although there is no indication that we should not do laser surgery in amblyopic patients, because I have done around 100 patients and I published a study also. And the study shows that if you operate in amblyopic eyes, vision is going to increase at least by 10% in all cases. More with the ICL, slightly lesser with the LASIK. So it will be at least BCVA or slightly more. It won't go down. So you can counsel the patient if he's happy with the BCVA preoperative and he wants just specs removal, we should go for the surgery. Because of the amblyopia, we should not cancel the procedures. And the most important is a normal pentacam or topography test. This is a must test for all the refractive surgery patient, whether ICL, whether LASIK, PRK or anything. And pentacam is the gold standard for screening these patients. So every refractive surgeon should know how to read the pentacam map. That is another important thing. So about the criteria, how much we should operate, how much number we should target in patient. So the criteria is not about the number, criteria is about the residual stromal bed, how much you are saving after the surgery. So there are different studies which tells that you should save 250, some says 275 or 300. So there are multiple studies and meta trials have been happened which have shown that if you save more than 300, your risk of ectasia goes down significantly. So we always try to save at least 300 micron in all our cases. Although there are many studies which have shown with 250 also you can get results, no ectasia, but ectasia happens in one case out of 1,000. But that one case is also big enough for us. So it's better to save maximum tissue that you can save. So with the recent concept, percentage tissue altered is another important concept. Apart from the residual stromal bed, what is the PTA value? So PTA calculation is very simple. Just use this formula, flap thickness plus ablation depth divided by CCT. For example, if you're creating a flap of 120 micron and you are doing ablation of 80, so it will be 120 plus 80, 200. For example, CCT is 500, so 200 divided by 500. So you will get PTA. If PTA value is 0.4 or more, then that's a problem. You should defer those patients for corneal brace procedures, go for the lens base. If PTA is less than 0.4, that's a green flag. You can go for the laser procedure. So this is very simple calculation. Even your optometrist can calculate and give you the value of PTA. Once patient comes in your room, along with pentacam, tell your optometrist calculate the PTA and write here. Because they can calculate what is the ablation depth and they know what is the flap. So they can easily calculate with pentacam CCT and give you the PTA value. So decision making is very easy with this formula. So these are the topographers that are being in practice. Pentacam, OpScan, Cassini, Galilei, there are so many. We use pentacam in our practice. So OpScan now obsolete, very few surgeons are using now, but it's still a very good device for refractive surgery. And you have to look for the chord map, you have to look at the abnormality in the 1.5 millimeter zone and 5 millimeter zone, 3 millimeter zone and 5 millimeter zone, and you can make a decision. Although the estimation of CCT is slightly lesser in OpScan, it gives higher values. So it's better to go for the pentacam test. So this is an example of normal pentacam. You can see the symmetrical bow tie. All the parameters are green, 42, 43. CCT is 554, so you can correct easily. So this is another scan, which is not a normal scan. So Bellin in pentacam map, you cannot make the decision on the basis of only 4 maps. Always go for the Bellin-Ambrosio display, because the main issue is to prevent ectasia. And this map tells whether this patient is suspicious or this patient is going to have ectasia in future, or this patient is having ectasia or any sign of ectasia. So always look for bad scan, that is Bellin-Ambrosio, enhanced ectasia display. And if you find any yellow or red flag, always defer corneal-based procedures. So there is a newer study which tells that if the wide to wide diameter, so this is a new concept in decision making for refractive patients. So if wide to wide is less than 11 millimeter, then you may see yellow spots in the bottom parameters or on the difference map. And if you see that DT value, if thickness of the cornea is normal and cornea is very steep, it may show that there is a yellow spot, but that cornea will be normal. So always look for the wide to wide diameter of the cornea. Smaller the diameter, it may show some signs of ectasia, but it is not ectasia, it is a normal scan. Although you cannot apply this rule on all the scans, so you have to look the patient in totality. Younger the patient, you should be more cautious. Older the patient, you may take the chance for going for the surface ablation in these cases. This is the age-old criteria of Rendelman ectasia risk factors, in which they divide the patient based on the topography pattern, whether it's symmetrical bow tie or asymmetrical bow tie. Residual stromal bed, again, as I told, more than 300, there is no risk of ectasia. Age more than 30, risk of ectasia goes down significantly. Pre-op thickness more than 510 micron, and pre-op spherical equivalent -8. So we can divide and tell the patient that in which risk category you come. So this is a newer classification in Pentacam. It's called ABCD classification, and it's based on the anterior radius of curvature, posterior curvature, thinnest specky, and distance best corrected visual acuity. And this formula will tell you whether the patient is safe to go for laser-based refractive surgery or not. Coming to the type of laser refractive surgeries, as discussed in the previous presentation, LASIK, microkeratome LASIK, femto, PRKs or surface ablation, and the newer tool is that is KLAX. So again, LASIK is a laser-assisted in situ keratomiliosis. You can get rid of glasses with this procedure. The treatment range starts from 0.5 and goes up to -10 diopters in most of the machines. While in case of hyperopia, 0.5 to 5 diopters, because if you go beyond that, it will be too flat, and there is a risk of regression also in hyperop cases. So you can club it with the cross-linking also if you are treating very high number. Astigmatism, again, 0.25 to 6 diopter cylinder. I don't treat patient less than 1 diopter because its number is very less. There is no need to treat 0.5 or 0.25 number. So the first is the microkeratome LASIK. So there are different types of microkeratome blades, and they are a very high precision oscillatory blade system which is docked on the patient's cornea, and the lamellar flap is created. It can be nasal or superior hinge flaps. So this is one of the surgery shown here, microkeratome LASIK. So this is the nasal flap. So it's always better to mark the cornea in all microkeratome LASIK. Although I don't mark, but I always advise it's better to mark, because in case of free cap or free flap, it's very difficult to locate the position or the exact location of the flap where to deposit it back. So it's better to mark on two sides so that you can correspond it and place the free flap back without inducing refractive error. So most common is femtosecond LASIK. Almost we all have shifted to femtosecond flap LASIK now, and there are different machines. It's very precise. Risk of getting free cap, buttonholes, free flap, almost none. So complication rate goes significantly down with all femtosecond laser machines. So just to show one video of femto flap LASIK. So this is done on the Visumax machine. So lifting the microkeratome flap is entirely different than the femtosecond flap. So microkeratome flap is a free flap. You can lift with any blunt instrument. There is no adhesions. But in femto flaps, you have to be very careful. There are some uncut areas also sometimes. So you have to be very careful. Go in a multiple step. Don't go in a single step. Unless you are a very confident or very experienced surgeon, go in a multiple or 2 or 3 step lifting, so that there won't be any problem in the flap. So coming to eximers, eximer is a derived from the contraction of excited dimer, and the goal of examiner is to reshape the cornea. So mostly patient ask you what you will do in laser. So we have to explain that we are going to reshape the cornea so that light focus on the correct point on the retina. So these are the different laser-based systems which are available in the market, and almost all the machines have shifted on the flying spot laser, which is the most accurate and quickest laser now. And all machines have the iris tracking system because patients move well when you're doing laser. So with the iris tracker, there won't be any effect on the ablation. So coming to the complications, there's some complications, although not very regular, like incomplete or complete or decentered flap, buttonholes, epithelial defect. So we have to be very careful in patients in which you develop epithelial defects, because if epithelial defect occurs during surgery, risk of epithelial ingrowth is very high. So it's always better to remove the entire epithelium in that area, put the BCL so that it can heal in totality. And then this is a scan showing post-LASIK ectasia here. So coming to the surface ablation was a very popular procedure in 90s. Then it goes down because of the post-PRK haze, and from last 1 decade again it is coming up very nicely with mitomycin C and with the advanced laser system. Now the haze incidents are extremely less, and recovery is very quick. Patient needs at least 3 to 4 days to recover, but after 4 days patient do very well, and complete recovery mostly take 1 month. So one more thing which we should be very cautious is to avoid any kind of infection in post-operative period, because I've seen many PRK patients developing infection in first week time, because there is no epithelium, you have already done the laser, cornea is compromised, and BCL is there, and you start steroid along with that. So I have changed, because I have seen many complications in my fellowship, so I've changed my regime of managing post-PRK patients. What I do, I don't start steroid in first 3-4 days until the healing is complete. Remove the BCL, then start the steroid. Patient will be in little pain for first 3-4 days, but you are sure that he is safe. He is not going to develop infection. Although recovery delays little bit, but safety is there. So I chose safety over the speed of recovery. So coming to the advantages of surface ablation, comparable visual outcomes, lower, not lower, it's no flap concerns, almost very less risk of ectasia, because you are ablating very minimal amount, no flap issues, so ectasia risks are not there. Quicker, cheaper surgery. You don't need microkeratome, you don't need femtolaser, you just need ablation, just examiner machine. And no learning curve also, it's very easy. And with the trans PRK, you don't need to touch the patient also, just put the speculum and machine will do the job. So almost no learning curve. Complication or concerns with PRK, discomfort initially, risk of infection, as I told. Some patient has delayed epithelial healing. So this is also a concern with some patient, because patient keeps on complaining with the photophobia, glare in post-operative period. So mitomycin help these issues, but not fully. Many patients complain. So it's better if patient is complaining, you can again put BCL, because patient has already recovered the initial epithelial defects. So you can put BCL in 2 weeks time, start on the steroid, then patient symptomatically free and recovers nicely. Then late complication, some patients also reported some loss of vision because of haze in the center. Then late complication, some patients also has diffuse haze or cholectasia. There is a tendency in some patients that they will develop more haze, like patient who have significant scar formation tendency or keloid tendency. So we have to take the history properly, whether they have these issues preoperatively or not. All patients who have collagen vascular disorders and facial rashes, significant inflammation on the lid. So in those patients, we have to be very careful, because they can develop slightly more haze. Then refractive complications, with PRK, if you're treating very high number, chances of regression is always there. So we have to be very careful. So it's always better to be slightly to the over treatment, so that if it regress 0.5 or 0.25, patient doesn't face any problem. And this is a publication with PRK haze, which tells with mitomycin C, the risk of haze goes significantly down. Coming to the last procedure, the KLX is a new term for all of us. So initially it was popular as a smile procedure with the Visumax machine. And with the newer machines, now JCR has decided that they have merged all the machines because it's clear, silk, smile, although all are same only. So JCR has decided that they will give the nomenclature of KLX, and KLX is a keratorefractive lenticle extraction procedure. So all procedures are called KLX now. And these are the 4 platforms which are available in the market, which does almost exactly the same thing. Although the branding is different, the cost is different. And one is from Zeiss, that is a smile, we all know. The next is a clear from Zimmer. It stands for corneal lenticle extraction and advanced refractive correction. The third one is silk from J&J. It is called smooth incision lenticular keratomiliosis. And the last one is from Schwind, which is called small incision guided human cornea treatment. So just a small video of smile. So it usually takes 20 seconds to do a smile procedure on Visumax 500, and the newer machine takes 9 seconds only to do this procedure. Advantage of this procedure is the suction is very in a normal human range, so only soft docking, it does soft docking, no subconjunctival hemorrhage. And because this is a very old machine now, almost more than 10 years, so the technology has matured with the Visumax, so you get almost consistent result in all patients. I have not retreated any patient in last 5 years. All patients are doing well, no regression noted, just 3 suction loss in last 5 years, and these patients usually do well. Next day, patient usually has 6/6 or 6/6 partial vision. It takes 4 to 5 days or maximum 1 week time when patient sees 6/6 nicely and without complaints. Learning curve is not too much. If you're a cornea surgeon, there is no learning curve. You're not a cornea surgeon, it will take 4 or 5 cases to learn this procedure. And coming to the last part, when not to do refractive surgery, the red flags, younger age patient, if patient is just completed 18th birthday, because we have seen many patients that today is 18th birthday, just remove his specs. So always counsel these patients to wait for some more time, because with rapid increase of myopia, there is chances that myopia can progress. He should ideally wait for 1 year or 2 year. High myopia patients progresses more than the low myopia patient. So if patient is coming with very high myopia, you have to tell patient that chances of progression in your case is slightly more than the patient who has a very low myopia. Again, the topographic pattern, if you find any signs of or any red flags on the topography, always defer cornea-based procedures. Very steep corneas, again, and thinner cornea, these 2 conditions always associated with keratoconus. So we have to be very careful with these situations. Absolute contraindication, keratoconus, scissors reflex, very steep cornea of more than 47, suspicious topography. Pupil size. Pupil size is very important to have the good outcome without glare and halos. So large scotopic pupil rule out LASIK if the optical zone diameter is smaller than the pupil itself. So never do a laser in these cases. The treatment zone should be at least as large as the scotopic pupil and never smaller than 6 millimeter. Thin corneas, although there is no clear guidelines when you should do up to what thickness, people are doing 480 also, 470 also for mild refractive error, but it's always better to be safe than sorry. So 500 or 490 is should be the cutoff in which you should touch the cornea. And the other important factor is, again, the RSB thing. You have to calculate how much you're treating, how much you're saving. If you're saving 300, so you're in safe zone, you can treat. If you're treating like 3 diopter or 4 diopter in 490 and residual is 300, you're pretty safe. So you can go for the procedures. Absolute contraindication, pregnancy, lactation, nursing. In these patients, we should not do surgeries. Again, the rashes, malar rash, and autoimmune disorders, because they have a tendency of scar formation and delayed healing. So we should avoid surgery in these cases. Also, any type of viral keratitis, old viral scars, because there are reports that laser has reactivated these infections. So we should avoid doing surgery. And the most important in today's world is a dry eye, So many of these patients are using contact lenses and suffering from dry eye, although they are not aware of that. So we should do dry eye workup. At least TBUT and Shermer's is a must for all refractive cases. And last, with the patient, if they are taking ISO39, we should ask them to consult their skin specialist, shift to the alternate drugs, stop it at least for 2 months or 3 months, then go for the laser-based procedures. And we often miss this situation. That's epithelial dystrophy or recurrent erosions. Many patients have old history of injury, and the scar is nicely healed, so we don't look it carefully. But if you take the history of trauma or erosion, then they will tell that sometimes they have pain or watering. So never do LASIK procedures in these cases, because the healing will be a problem. All contact lens users usually have vascularization, limbal vascularization. So in these cases, discontinue the lenses for a month, start on FM and lubricant. Once these vessels settle down, this cornea becomes, conjunctiva becomes quiet, then go for the laser procedures. So in conclusion, proper history taking and examination can help in correct decision making. Corneal tomography is an invaluable tool before planning refractive surgery. Never do refractive without tomography. No laser-based refractive surgery should be done without this. And all patients are not fit for refractive surgery. Choose judiciously. Thank you. Thank you.
Hanji.
Any questions from the house?
Yeah. So my post-op regime is, so from day one, I start patients on antibiotic with some anesthesia added in that, xylocaine, so that patient will have less pain. And along with that, lubricant, Nevernac, and cyclosporin, so that it will take care of inflammation. Nevernac and cyclosporin will take care of his inflammation. And on 4th day, I remove BCL. I stop everything except lubricant and cyclosporin, and I add FML in that. FML 4 times for 1 month. After 1 month, I call patients. If patients are doing fine, 6/6 vision, no problem, stop FML. If they complain that sometimes they have a problem, you can taper it, make it 2 times for 1 week, 1 time for 1 week, and then after 2 weeks, you can stop. And the restasis, I usually give for 6 weeks. If patient shows some signs of inflammation or some minor complaint, we can extend it for 3 months. So this is the post-op regime. But with not using FML in first 4 days is a very peaceful thing for surgeon, because you're sure that there won't be any infection. So that's because I have treated many patients that come from periphery. They've done the PRK, then full cornea is melted, bilateral melts. So that's a problem.
How much
So both the method, if you don't have the machine which has trans PRK, you can do the manual ablation, manual removal with the hockey stick knife. If you have a trans PRK machine, so the laser will do the entire job. And if you talk about the result, there is no difference in the result.
How do you decide by PTK how much epithelium?
So PTK,
50 microns,
so
55 micron, or
so it's very difficult to say. You have to see the color change on the cornea, because the newer machine like Schwint and Elcon, they have the trans PRK softwares. So if you put a software, the machine will decide how much the machine has to remove, and then it will start the ablation for the correction. But the machines which don't have the software, in those machines, either you can do epithelial mapping to know what is the thickness of the cornea. You can decide on that basis. Second thing, with experience, you know it will change the color. Once the epithelium is gone, the color will change, so that you can decide accordingly.
Sir, is there anything like below 2 diopters you do normal conventional PRK, and above 2 diopters you can go for trans PRK? Is it something?
As I told you, there is no difference in outcome. The result is same, whether you are removing with the laser or whether you're removing with the hockey stick knife. There is not a much difference.
So even if it is low
Yes,
power, you
yes.
go ahead with trans PRK.
No problem in that. No problem. Yes, always.
She is also using isoretinin. So then in that case, what you will do? You have to do C3R for that patient.
Okay. So you have to stop the isotretinoin if you are doing any laser-based procedures, because it will increase the scarring, post-operative scarring. So there are now newer drugs that skin specialists shift them temporarily. Okay, once the cross-linking is healed, after 3 months they can go back to isotretinoin. There is no problem.
So anyways, in C3R we are inducing scarring, na, sir. We want scarring to happen in.
No. So isotretinoin along with scarring, dryness is the main issue actually with isotretinoin. We stop isotretinoin because of the dryness, not primarily because of the scarring.
Also isotretinoin increases the progression of myopia and increases the size of the lens, causes shallowing of the anterior chamber, increase in the IOP. So there are many things which isotretinoin is doing. So the most important thing about this thing is that it increases the myopia also, a temporary increase. So you stop it, whatever myopia stabilizes, then you do. Otherwise, wait till, sometimes it can increase myopia by 5 diopters. That is what I have seen in my practice. So sometimes it is, very, very challenging thing once the patient is on that for whatever depression or they're using it for. So it's you have to be very sure that the effect is totally gone before you can touch the patient.
So after how many days you will take up for C3R?
First you have to, for C3R there is no urgency, because at least let the patient stabilize because this is antidepressant also. So you have to take the consultation with the psychiatrist also. For the patient, go back, because you are not the person who is prescribing it. Majority of time, the psychiatrist prescribes it. So you have to ask them.
Isoretinin mostly they will be prescribed by
skin
dermatologists. That is topiramate. What you were telling was topiramate.
Okay. Sorry, I'm sorry for that. Yeah, I confused it.
And regarding testosterone inhibitors, some patients are using for hair transplant and all. Is there any need to stop before LASIK surgeries?
Finasteride and all.
Testosterone inhibitors.
No experience.
No experience about that. We need
Many
to- we need
patients,
to look
they
for
are
the literature.
they use hormone therapy, they are on, and for endometriosis and many other things, the young girls. So,
PCOD and all.
yeah, PCOD.
Yeah, so most of them
So, but,
are steroids only.
Yeah. So, but I have discussed with many LASIK surgeons. They say that they don't. They don't stop or they don't do anything. Because they are on hormone therapy, so whether
We are not doing in pregnancy and lactation mainly because of that, right?
because of that reason. But when if we can stop for some time, they have recently started. Then I stop the hormone. I ask them to consult their gynecologist and then decide
So
if
is
they
there
can
any
stop.
limit, like we are stopping isotretinoin 2 months for 2 months? Is there something like that, or 1 week or something
1
else?
week won't help.
1 month, I think. 1 month is something we
Because
should.
most of these drugs are steroids only.
Yeah.
So we have to
Because after lactation also, we ask them that once they have started, so they have to wait for 1 to 2 months or 3 months, then we can do LASIK. Otherwise, we don't. Dr. Sain's
We go
question
on
was-
for the next talk, because we are running
yeah.
short of the time. It is
Just
only
a-
20 minutes now left.
Yeah.
So Purendra will take his next talk. That is on lens-based refractive surgery, options, investigations, and considerations.
C-type.
After that, we'll discuss.
C-type connector. Dr. Sain has asked one question about the epithelial thickness. So nowadays what I do is, and it's part of our pre-operative examination, LASIK workup, is epithelial mapping. That we do in all cases and see what is the average thickness and maximum thickness, and that we take into consideration. 55 micron is the cutoff, and maybe 60 microns I am taking now. So that the post-operative recovery is faster and better. ASOCT, epithelial mapping is separate, that you have to add to it. Thank you, Dr. Bharti sir, for giving me this opportunity and to speak on lens-based refractive procedures. and my experiences on this. I've been doing this ICL for last almost 19, 20 years, and I'm having very good experience with it. And the lens-based refractive procedures include the phakic lens and the clear lens extraction. So this is something which is meant for the dropouts, which Dr. Bhupesh and Dr. Bharti sir uh, were not, I mean, we could not do the cornea-based procedure or laser-based procedure. In those cases, we should do it. So I'm Purendra Bhasin from Gwalior. No financial interest. So lens-based procedures are the options for refractive error corrections in eyes which are unsuitable for corneal refractive surgery. They address the eye's lens system to correct the vision rather than reshaping the cornea. So we do phakic IOL, or this includes clear lens extraction. So phakic IOL is the which we all must be knowing by now. It's an insertion of a biocompatible lens between the iris and the natural crystalline lens. So the great advantage is that it is an reversible procedure, and it does not involve the removal of any corneal tissue. So any problem associated with LASIK, they are, or the cornea, they are avoided. It's a better option for candidates unsuitable for corneal refractive surgery. In comparison, clear lens extraction involves the removal of the natural lens and replacing it with an IOL, which we have been doing since ages, and to correct the patient's refractive error. It is similar to cataract surgery, but is performed primarily for the refractive purposes in patients without significant cataracts, especially beneficial for those with presbyopia or with high refractive errors that are not suitable for corneal refractive based procedures. So the advantages are that we can correct very high myopia or high hypermetropia. Clear lens extraction with multifocal or EDOF lenses is suitable for older age group patient, as it addresses presbyopia and future cataract development also. It preserves the corneal integrity. There is a reversibility and adjustability, and there is reduced risk of dry eye. So phakic IOLs, let us go one by one. So I will be now speaking on phakic IOLs. It is advisable in patient as per the company, Star Company. They say it has to be used in 21 years of age and above, up to 45 years of age. What I think over here we do, when the refraction is stable for last 1 year and there is no change in refraction in last 1 year by more than 0.5 diopters. It is suggested in patients who are LASIK rejects, like in high myopia, when the cornea is thin, less than 500 micron, or the myopia is 6 diopters and corneal thickness is 10 diopters or so, 505 diopters, then also we should avoid it. And dry eye, significant dry eye, large pupils, excessively flat or steep cornea. So, and contraindications for the phakic IOL is that there is a presence of lens opacity, pseudo-exfoliation, coloboma lens, zonulopathy, pigment dispersion, or then we should avoid any previous ophthalmic surgery, any other ocular pathology like glaucoma, uveitis, corneal degeneration or dystrophy, macular pathology or neovascularization. Indications for phakic IOL are that it can be used to correct myopia, hyperopia, astigmatism, or stable keratoconus. And the off-label use, it can be used for post-refractive surgery patients, post-cross-linked patient, post-keratoplasty, as in piggyback for correcting the residual refractive error post-cataract surgery, post-RK surgery, etc. Pediatric anisometropia, Sometimes in few number of cases I have done at 15, 16 years of age, when the child is having unilateral high refractive error of 17, 18 diopters, which cannot be corrected otherwise, and we cannot give glasses or contact lenses to these children. And presbyopia can also be corrected with the newer presbyopia correcting IOLs, but the presbyopia correcting phakic lenses, but the indications are limited. A complete preoperative assessment is done: uncorrected, best corrected visual acuity, refraction, manifest cycloplegic, slit lamp examination, mainly to assess lens, cornea, and the surface. IOP, no glaucoma, angle should be open. Topography, rather better is to go for tomography, keratometry. Endothelial cell count should be more than or equal to 2000. Fundus examination, normal peripheral retina or retinal pathologies are photocoagulated and safely time is given, interval is given in between. The two important things which are specific for the phakic IOL is the measurement of the anterior chamber depth, mainly the depth which is from the internal anterior chamber depth, which is from the posterior surface of the cornea to the anterior surface of the crystalline lens. It should not be less than 2.8, that is what is indicated. And corneal horizontal white to white measurement. These are the two very important things. So coming to my first case, which is 23 years old female with optimum Pachy, but the refractive error was, as you can see, 8.5 diopters in right eye and 6.25 diopters in left eye. Right eye, we cannot, there is a risk of development of ectasia if we go with the normal full correction. So to obtain good vision and full correction, we suggested her to go for ICL for the safety, and the toric ICL was implanted in both the eyes, and post-operatively vision was 6.9 and 6.6 in the left eye. So this is the case and the surgery. I do not dilate now and before the surgery. I put, because these incisions sometimes can damage the natural crystalline lens. This lens comes in a BSS in a bottle. It's a front loading system. With this soft spatula, the lens is taken out from the bottle and placed in the hub of the cartridge, and then it is pushed inside into the anterior chamber over the surface of the iris, and then with the help of lens spatula, the haptics are tucked behind the iris, and the viscoelastic is aspirated, and there is a central opening which is a centraflow of 360 micron, which equilibrates the aqueous from behind the lens, and from in front of the crystalline lens, the aqueous moves around the lens, and the nutrition of the lens is not hampered. So this is the toric lens, and we can see it is very well aligned. You can do a manual marking also. Another case, 42 years old female, near presbyopic age group. So with high myopia in both eyes. So what I did was, in this particular case, the Pachy and rest of the things were normal, keratometry was normal. Patient had a myopia of 10.25 diopters nearly in both eyes. So left eye we did under correction by 1.25 diopters. So this monovision we create, and by now we have done almost 10 cases, and with fairly good results. In all these were of presbyopic age group, and up to 52 years of the age I have done, and from 40 years of the age group. So all these patients were quite happy with the monovision vision, we have explained them beforehand. So now, in cases of keratoconus, as the cornea has been stabilized, keratoconus has been stabilized, and we should wait for 6 months after the cross-linking. I wait for more, and a clear central cornea should be there, and the cone also should be central. Contact lens intolerance should not is there, if the patient is not able to wear the contact lens, they are indicated, and patient's quality of life is being affected, then we should indicate. And this has been done since 2007, that the ICL is being implanted in keratoconus patients. This is a graph which tells us, like, for high corneal abrasions, cross-linking and trans-PRK should be done before, and we should make the topography and refraction stable. We should wait for minimum 6 months or more, and then we can think of planning ICL. And for the decentered cone with poor best-corrected visual acuity, we should plan for intacs and with or without CXL, and then we should wait for 6 months or more and then plan the ICL. So this 28 years old female with both eyes stable keratoconus post CXL, 14 months later we planned for the ICL. The refraction was 8.25 diopters myopia with 3.5 diopter cylinder, and with similar in the left eye also. This was the topography, and surgery is similar, and post-operative refractive correction is very good, and patients most of the time, in majority of these patients, are very happy in their visual outcome. Sometimes there is improvement in the vision also. So surgery is similar, and we have to mark the cornea like we do it in any toric IOL cases pre-operatively and intraoperatively. This I am doing with Varion, so this is without any marking. So high cylinder, the exact location of the ICL is very, very important. And keratoconus, there is a central anterior chamber depth. Usually we get a falsely high anterior chamber depth. So that has to be kept in mind, because because of the keratoconus, the posterior surface of the cornea is ectatic and anterior. So white to white measurement should be very good, otherwise there is a rotation of the lens. So post-operatively, vision has improved from 6/9 part and to 6/9 in both eyes, and we measure with the both eyes, then it should be around 6/6 part in both eyes. Another lady, 36 years old female, and post keratoconus, right eye squint surgery has been also been done, and there is amblyopia in right eye. Improvement in vision is 6/18 part in right eye with 1.5 and 5.5 cylinder, and in the left eye 2.75 with 2.25 cylinder. So this is the topography, and central cone is there, so we plan for ICL. So toric ICL. So 5 years outcome of EVO Vision implantable lens for the correction of high myopia and super high myopia says that the results are good, and there is no the predictable outcome is there, and there is no side effect or complications. And another study, refractive outcome and safety of ICL in young to low to moderate myopes up to 10 diopters, that also says that the results are good. So coming to the second part, that is the refractive lens exchange or the clear lens extraction. So this has been done since 1776, a removal of crystalline lens for the refractive procedure. Even till few years back, I was not doing this procedure, and I have not done it in the past, but for last few years I have started doing it, mainly for the hyperopic cases. The refractive lens exchange is over laser vision correction. The high myopes and hyperopes can both be corrected with refractive lens exchange, sometimes with superior outcomes. And refractive lens exchange precludes the need for cataract surgery in the perigeriatrics. So in the presbyopic age group patient, it gives an added advantage that we can correct the presbyopia, and later we don't require to do the cataract surgery also. Laser vision correction can cause dry eye issue, which is not there with this, and makes future IOL power calculations more difficult. And the specific indications are for the high refractive errors, maybe 10, 12 diopters of 6 diopters, 7 diopters, or of hyperopia, or maybe very high myopia. The downside of clear lens restriction is loss of accommodations, and we need reading glasses. Maybe we can do the monovision, and placement procedure is more invasive than laser refractive surgery. It is difficult to implant as compared to phakic lens, and there is a challenge in accurate IOL power calculation. If you don't have high-end biometry instruments, it is better not advisable, because we will not be as correct. But unless the myopia or hyperopia is too high. So options are monofocal lens in both eye with monovision, or we can implant a multifocal or EDOF lenses. The complications which are there, the most important thing is the rhegmatogenous RD in all these cases. So various studies are there, which has been shown. This is the meta-analysis has been done. So mostly these were up to included the studies up to 2007. So with the newer machine, newer technology, newer biometric instruments, and better understanding, we can now do better cataract refractive surgery in a more predictable way. And the incidence was from 1.5 to 8.1% in all these studies. So the conclusion out of all these studies is on the right side. The increased risk occurs when the myopic eyes have an axial length of more than 26 millimeter, when the spherical equivalent is more than -6 diopters in myopic patients, age is less than 50 years, peripheral retinal degenerations are there, or there is a rupture of posterior capsule during the surgery, and NDR capsulotomy for PCO. To avoid RD retinal detachment, detailed fundus examination with scleral depression should be done by the retina person. There should be minimal manipulation intraoperatively. So fluctuation of the anterior chamber should also be managed. And what I do in all my cases now is I fill the chamber with viscoelastic before removing my aspiration handpiece. And prophylactic laser should be done if there are lattice or peripheral retinal degeneration. Other complications which is increased in number is CME, PCO, myopic CNVM, and the IOL related issues like glare and halos, and dislocation and decentration of IOL if the size of the lens is small or the lens bag is larger. Others are suprachoroidal hemorrhage or endophthalmitis post or surgery. So when not to perform refractive lens exchange in myopic eyes is when there are advanced peripheral lattice degeneration, when we see the lacquer cracks in the retina, and presbyopic eyes with macular degeneration beginning in the fellow eye, or patient is having diabetic retinopathy, etc., and other macular pathology, foveaceasis, etc. This is a young girl with posterior polar cataract. All of us will agree in myopic patients, we all do surgery if the even in the younger age group when they have a posterior polar or some cataract changes are there. We all must have done it. So with that, we got an incentive or an idea that why not to do a refractive lens exchange also when we do it in safely and our results are good in even in younger age group without the cataract. So this was she was having a high myopia of more than 6 diopters with cylindrical power. So rest of the things were good. So we planned for a toric trifocal lens with the femtosecond laser. IOL power was 11.5 in right eye and 13 diopters in the other eye. And post-operative day 1 vision was both eyes was 6/9 part, and with pinhole it was improving to 6/6 part. So this is the surgery, and with some posterior subcapsular cataract. And before coming also, I did on a young girl. She is working in some serials, acting in profession. It's a small PCC, and patient was not very happy, and she was not a candidate for the laser vision correction, or we will not do ICL in these cases. So, minded many are doing, and this is the IOL power. In this eye, trifocal toric lens has been implanted, and the lens axis is aligned with um, the at the steep meridian, and this is the surgery. So in all these cases, IOL should be well centered, it should be well covered by the capsular axis. Our surgery should be immaculate, posterior capsular polishing should be done. This is for the other eye which we have done. I will take it further. And the lens is small, so we can do it with the irrigation aspiration and so hydroimplantation. The lens is opened up in the bag, and chamber fluctuation should be avoided, because then the traction on the periphery or the base of the retina is not there. So complications can be uveal effusion, hyperopia. We can do these cases, and I prefer doing more in cases of hyperopia. And the indications are beginning presbyopia with weak accommodation. For higher order aberration, when laser surgery is to be avoided, can be used for extremely short or nanophthalmic eyes or eyes with residual hyperopia post laser vision correction, and high hyperopia in patients with congenital systemic conditions. The complications in hyperopia are different than in myopia. You can have a uveal effusion, which is a known complication, and small eye, less than 21 millimeter, the anterior chamber shallowing is there, high predisposition to closed angle glaucoma due to pupillary block or secondary to rise in intraocular pressure. Complications like RD or cystoid macular edema are less as compared to the myopes. This 30 years old young girl came to us with a high hypermetropia, 7.5 and 9. We cannot do laser vision correction because we can correct up to 6 diopters. Because in left eye the residual refractive error would have been more, so we planned for trifocal IOL in both eyes, 33 diopters, and patient's visual outcome was 6/9 part and 6/6 part, and N6 in both eyes. She is very happy. And this last case is very, very interesting. 22 years old female, both high hypermetropia, very high hypermetropia with amblyopia. We did bioptics for her, and preoperative refractive error was plus 12 diopters and 0.5 cylinder, improving to 6/9 in both eyes. So these were the parameters. So IL power which came to us with IL Master 700 was 49 diopters in right eye, and nearly same in the other eye too. So because the lenses in hydrophobic acrylic category, I prefer doing in all my cases hydrophobic acrylic lenses only. So I don't do hydrophilic acrylic. So plus 40 diopters lenses are available from Alcon company, monofocal lenses. So that I implanted. I explained her, if she will not, she is not comfortable with the present vision post-operatively, we can correct the residual refractive error by LASIK after 3 months or 2 months or so. So post-operatively, vision was 624 in right eye and improving to 612 with 2.5 diopters, and in left eye with 0.75 diopters of residual refractive error was there. So hyperopic PRK was done after 2 months of the IOL surgery, and patient vision in right eye is 6/9 and 6/12, what it was beforehand, with these spectacles. So this is this surgery, this is clear lens extraction. And what other thing I did in this case was I did a primary posterior capsulotomy, because these young children, the young patients, there is a high chance of development of PCO in early age group. So this is clear lens, and this was done nearly 2 years back, and the she has come from some 300 kilometers away from Gwalior, this patient. After filling the chamber, hydrophobic acrylic plus 40 diopters lens, and we have to use C cartridge because these lenses are very bulky, and our incision size should also be 2.8 millimeter. Otherwise, it is very difficult to push these lenses, and we have to push it slowly, and viscoelastic should be filled in the cartridge also, and lens is in place. Remove the viscoelastic, and with the vitreous cutter I will do make a central opening at the in the posterior capsule. So this patient didn't had any PCO in the early post-operative period, and this is also very safe. So here, this is the left eye for this same girl. We took it after 15 days of the first eye, and I will fast forward it. After removing the lens meter, there is again 40 diopters in the other eye, and technique is same. PC opening is made with the vitrector after removing the viscoelastic, and central opening is created. But our surgery should be immaculate, and you should not proceed to go for these kind of surgeries unless until you have an experience and your results are good. So CLB is a clear lens extraction in presbyopic is to restore distance, intermediate and near vision, and we can implant multifocal or read-off lenses. The issues are the incidence of PCO and long-term centration of the IOL has to be taken into consideration. So our surgery should be without any complication, and our capsular exercise should also be adequate. And what IOL power selection and is no different from standard calculation when we use for the cataract surgery, and there is a loss of accommodation should be discussed with the patient when the patient is too young, or we may use EDOF lenses. Small degree of myopia may be desirable in monofocal IOL usage, and monovision is suggested. It is reported that in eyes with extreme axial length, the Barrett Universal 2 formula is the best, and I am using Barrett Universal 2 formula, and it has got the lowest predictive error rate. And these are some studies. Visual outcome and patient satisfaction after bilateral refractive lens exchange with a trifocal intraocular lens patients in presbyopia, a presbyopic age group. And another study of this kind, and the literature also says that the results are good. And this is a study which tells us compares between clear lens extraction and phakic intraocular lens. They summarize that with advancing technology, with better newer IOL models, refractive lens exchange and phakic corrections are becoming available. And phakic IOLs provide better visual outcome for distance correction. And we should, last slide, going for the conclusion. Phakic IOL is the procedure of choice in all young patients and in LASIK rejects. And in elderly myopes, phakic IOL is the choice with monovision, or maybe presbyopic ICL if we can opt for. Clear lens extraction is opted with retina clearance and in the presence of PVD if it is there, or with early cataract. That is what my take-home message is. In hyperopes, LASIK and phakic IOL rejects, clear lens extraction is the choice of procedure. And in high hyperope, I prefer to do clear lens extraction when we cannot do LASIK or phakic IOL. Thank you for your patient hearing. That is not available. But they are available in hydrophilic acrylic category. All these Care Group and Appasamy, they make it for us. But all these lenses are hydrophilic acrylic, not the hydrophobic acrylic.
Any questions?
Sir, in the corneal procedures, anything which is really good working well for presbyopia?
Sorry, anything which is working in corneal procedures, yeah, presbyopic LASIK is reasonable. The only thing is you have to fine tune it in your machine and in your hands. So in my hands, a 1.6 times correction of the hyperopia along with presbyopia works well, but not to the extent that it is very. The other thing is presbyopia is a dynamic process. So it works for about 5 years and then gradually patient starts needing glasses. So that is why presbyopia is a very subject of patient and surgeon's choice, whether they agree to whatever is dynamic and they want to get it corrected. Of the hyperopia what the patient accepts, and then I corrected 1.6 times.
So you do full cycloplegic
No, not
refractions?
full. No.
You
Not full
take
slide.
subjective.
Subjective into 1.6. If I do cycloplegic into 1.6, that will be too much. And mostly, even with the presbyopia, the correction is not beyond 6 diopters. So mostly about 2.5, 3 diopters hyperopia plus presbyopia, or minus power we don't do in presbyopic correction at all. So it's only low hypermetropia plus presbyopia. Or even e-metro presbyops are not very, very happy. Though we do it, and I did it almost 10 years, more than 10 years back, they are not ultimately very happy with the results. So it's only the hyperopes who are happy.
And sir, if a patient is coming for late 40s, like 38, 39, and now you have EDOF ICLs also. So would you recommend that, or would you recommend undercorrecting?
ICL, the problem is that they say that you will have very tight range of 4 to 6 diopters of myopia for the ICL, presbyopic ICL. Anything beyond that, and 45 to 42 to 46 or whatever age. So it's a very small range of presbyops that you can correct. Myope, presbyopes.
I think, and other issues of glare halos are also there associated with the presbyopic ICL and Indian lens, presbyopic lens. So I think better it is to do undercorrection, monovision, and both eyes, if it is there, that is the best.
Thank you, sir.
There is more forgiving.
Thank you to the participants and the delegates who are here. Thank you very much for coming and attending our course. Thank you.
Thank you. Let's come for
Take
the picture.
picture. Yeah.